Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Adam Lewandowski. He's a university research lecturer and British Heart Foundation research fellow. He's at the Oxford Cardiovascular Clinical Research Facility, CCRF, the Division of Cardiovascular Medicine. He's from the US. He sounds like it at least, or Canada, but he's over in England. So, Adam, thanks for coming.
Hi, thank you. Yeah, so I'm Canadian.
Okay,
so,
Canadian.
Yeah, but I moved to the University of Oxford in 2009 to come start my PhD studies. So I've been here for almost 11 years now.
Oh, wow. So what's the focus of your work?
So the main area of my work is looking at the effect of pregnancy complications. So specifically related to things like preterm birth, so being born early, and how that affects heart development and the interaction with other systems, organs, so things like the brain, liver, and blood vessels and lungs, and how all of those things are changed within people born preterm.
So preterm birth, is it divided into like very early preterm, late preterm, or is it just one monolithic thing?
No, exactly. So there are different categories, largely based on gestational age. So normal gestation would be between we say 40 weeks is your full term, but that can actually, the full term definition actually ranges from 37 to 42 weeks gestation. Anything less than 37 weeks gestation is considered preterm. But you're absolutely right. So there's different categories. So if you are 32 to 36 weeks plus 6 days, you're considered moderate to late preterm. If you're 28 to 31 plus 6 days, weeks gestation, you're considered very preterm. And if you're then less than 28 weeks gestation, you're considered extremely preterm.
Are babies able to survive if they're born super early? Like what's the earliest that you've seen that it's possible for a baby to survive and develop?
So the earliest that I've seen within like a hospital setting has been 22 weeks, and that's becoming more and more common, actually. So I know some centers actually in the US, there was a study published out of Iowa that actually showed that even 22 to 23 weekers, I believe the figures of about 60 to 70% survival now within that cohort of individuals, which is pretty impressive actually, because we wouldn't have seen that, say, 10 years ago.
Yeah.
But I would say the survival rates in general for preterms are now up in the 90% across all the gestations. Yeah.
So when does a baby's heart develop, throughout gestation, and what features of the heart develop when? Yeah,
so I think intuitively you would think that may not have a big effect, because if you go back to like physiology, when we learn about development of organs, actually the heart's fairly early on. So within the first weeks and actually within the first couple of months, you already have, by week 7, week 8, you already have that functioning chambers and heartbeat function like of the heart. Now the reason why, whereas with the brain, a lot of that developmental period is actually very late in gestation, and that formation of the different components of the brain. But the reason why this is important and why prematurity affects the way the heart is developing is because in the later periods of gestation, there is a big period, an important period of growth for the heart. So what we have is early on is something called hyperplasia. So that's when the cells are rapidly dividing in order to expand the myocardium, which is the heart muscle wall. And as you move towards later bits of parts of gestation, that you'll see the heart actually start to increase several fold larger over those last weeks of gestation. But once you switch towards the outside environment, you have changes in, you have a big shift in the pressure and the flow around the time of birth. And then you have those pressure and flow changes outside of the womb as well, because you're now faced with a situation where you have a functioning pulmonary system, and you also have a high resistance systemic system, whereas inside the womb you had that low resistance placenta. You've also got these shifts in oxygen tension and everything too. And what you see basically is that the cells change from that hyperplastic growth to a hypertrophic growth. So the individual cell size is actually increasing.
Oh, so could a baby end up actually with a heart that's too large too early for their size if they're born prematurely?
Because you're actually affecting what we don't tend to see that as much, because what you're actually affecting is if you disrupt the amount of cell division, but you're increasing the actual individual cell sizes, it may not be that the overall heart size increases. We actually see the opposite. We actually see that we have smaller internal cavity diameters and smaller actual functional diameters for matched gestational ages, but then that you actually get a thickening of the wall.
I've heard, I believe when someone has a heart attack or heart problems later on in life, that's exactly what happens is you get, part of the heart dies off and the remaining cells in an attempt to cover everything become hypertrophic. So I wonder, babies that are born prematurely, if later in life they have less cardiac reserve if they have heart problems because they have maybe fewer cells overall and they're hypertrophic already.
Yeah, so this is so we call this kind of the reduction in cardiac endowment that they have. And the studies that I've been doing have kind of expanded from or gone across all the way from looking at kind of early fetal development of the heart, largely in humans, but in collaboration with other groups that do work in animal models, but also looking what happens in those first weeks to months in the postnatal period. So once they're neonates, infants. And a lot of my PhD work was focused on the adult period and looking at what those kind of long-term effects were just in terms of morphological changes. So things like structure and function, volumes type things. And what we've seen is that they do have these distinct changes between the groups, which may adversely affect them in the longer term. The work that I've been doing in my postdoc, which was started in 2013, and now transitioned into my role as a PI now running my own research team, has been to try to link up what's actually happening at a tissue level, what's actually happening to the heart when it's faced with physiological stress demands, so things like exercise stress, but also what's happening at a cellular level as well. And understanding how that heart development changes throughout a life course. So we've actually followed some of these same individuals that have been seen early in life, so during fetal and neonatal and infancy, and are actually tracking them into childhood now. And some of the findings that we've been seeing from primarily in our young adult studies is that when they are faced with that kind of stress response, so when they are put into moderate to high intensity exercise levels, you're exactly right. What you brought up before is that they have this reduced functional reserve. So we call it a myocardial functional reserve, and they're less able to elevate the amount of contractility of the heart and amount of blood volume needed to meet the demands of the body.
What about when a baby is born prematurely in the incubator system? What does this tell you about how to set the pressures, maybe the percentage of oxygen? Is there anything you can do to try to encourage the heart to continue more normal development instead of just going hypertrophic?
Yeah, so I think that's still a remaining question, actually, is what is the best environment? And one of the challenges that we have is that in a very positive way, clinical medicine is advancing quite quickly. And the absolute main thing to remember is that what needs to be done in immediately clinical care to keep the babies alive is the most important thing as well. So understanding what's actually going to be able to achieve that immediate benefit, but also promote potentially long-term benefit or reduce long-term harm has been a challenge that we can only right now look at in terms of a correlative manner. There are some studies now investigating specifically the effects of different oxygen, amount of oxygen exposure, different ventilation parameters and things as well. But the challenge with those, and what I am hoping for the future, is that a lot of the follow-up that's being done is very short-term. And what we're actually seeing is that we need follow-up into longer term. And I don't mean until elderly life, I mean at least until childhood. Because coming back to that kind of risk of preterm born individuals, we are seeing from big epidemiological studies now that actually these cardiac changes may be making them vulnerable already in not just long term, but it may have immediate risk, because we're actually seeing that they have an increased risk of heart failure early in life, so childhood, adolescence, and into young adulthood, and even by young adult life have increased risk of hypertension, including higher number of hypertensive medications, even in their 20s. And they also have an increased risk of ischemic heart disease.
What causes babies to be born prematurely? Like, what are the main drivers of it?
So there's a number of different causes. So there's things that can be familial. So you can have, genetic predisposition that may make you deliver preterm. One of the biggest antecedents to prematurity is actually preeclampsia, which is a more severe form of a hypertensive pregnancy. So that can account for up to about 20% of preterm births. Things like infection can also lead to preterm birth. And then you have other risk factors, including things like obesity and smoking as well.
In general terms, what have you observed that's done, even without specifics, but generally, what do you see that's done for the premature babies?
So the main thing is obviously maintaining appropriate, so in terms of monitoring and maintaining their lung function. So things like providing surfactant, but also providing oxygen to make sure that the brain and body's needs are being met. And the other aspect of that, of course, is one of the struggles of early with preterm neonates is the fact that feeding is often quite challenging. They're often very small. So providing parenteral nutrition and providing appropriate feeding is an important component of that. And of course, because of the immature physiological system, they're also more prone to infections as well. So kind of taking a prophylactic approach to that is also an appropriate component.
And then when a baby is premature, what happens to the heart, let's say in the first, what do you call the gap between the time the baby is born until it would normally be born? Let's say the 40-week mark. Does that gap have a name? And if so, what happens to the heart in that time? And is that different from what happens to the heart after that? Let's say a baby's born at 30 weeks. And, you said like full term, let's say I'm just going to say it's 40. I know it's a range, but so is that 10-week gap called anything? And if so, well, whether or not it has a name or not, what happens to the baby's heart between week 30 and 40? And then what happens, 40 and beyond? Is it different, or does the same thing happen on the heart, whether the baby's born at 30 weeks or 40 weeks?
Yeah, so that's a good question. So, I mean, in general, it's called the kind of preterm postnatal period. And once they've reached kind of term gestation, so say you were born at 40 weeks, you would then say term equivalent age of the preterm born individual. Once they reach, say, 42 weeks, which is 12 weeks postnatal, would be what their term equivalent age would be. That what happens during that period, we can use some of the investigations that our own group as well as others have looked at in terms of looking using MRI and echocardiography, which have shown that the heart in that period undergoes very similar changes to what you would normally expect to happen later. And that includes the fact that you switch from a right heart dominant to a left heart dominant system. And again, that's to maintain the required demands for the lung system, which is much lower resistance than, say, the systemic system, which is why the left ventricle remodels to be able to take over that flow through that system. But again, going back to the cellular shifts is we see that big shift in hyperplasia to hypertrophy, so the way the cell's dividing to being more hypertrophic. The other aspect of that is that from a lot of this has been our understanding of how the heart remodels has had to rely on investigations from animal models. So studies in rats, sheep, and pigs have kind of been the main ways of actually interrogating this. And the big thing that's been found from that is that although there are these, so the cellular growth shift patterns, but there's also been changes at the DNA level in terms of nucleation as well, which is shown to have abnormal maturity within the individual myocytes, but is also shown that outside of the individual myocytes, you also have differences in the structural components of the heart, so the collagen content within the interstitial spaces, which may be driven by pressure overload. Now, one of the things that has been discussed as well is that a lot of these models can't mimic the full preterm birth conditions, which often involves things like inflammation, especially if you had underlying placental abnormalities, which is common in things like preeclampsia, which I mentioned is a major contributor to preterm birth. So if you have those changes as well, it's suspected that you're going to have more of this collagen deposition, fibrotic formation as well, which may make the heart less compliant and less able to meet the demands of the body as well.
Does the heart have a different shape? Is it preferentially like thicker in one of the ventricles, for instance, or does it look pretty close to what a normal heart looks like? Like, how different are they?
Yeah, so a lot of so our group has been largely using MRI, and we also use computational modeling. So we work closely with biomedical engineers in order to actually interrogate the 3D structure of the heart. And by young adulthood, what we've seen is that the ventricles are actually smaller internal cavity, similar external cavity, which is suggestive of an inward thickening of the muscle wall, and shorter ventricular lengths as well. So, and this seems to be consistent with both ventricles, though we've seen greater changes in both the remodeling as well as the amount of systolic function, so the pumping function of the heart in the right side. One of the things that we believe this could be due to is it could be related to part of the link with the pulmonary circulation. And we have published on this as well, but this effect with the pulmonary circulation seems to be more driven in those that are at earlier gestations. The other, so in terms of looking across all of the different developmental stages, we just actually on the 7th of July, meta-analysis in pediatrics will be published from our team that we've actually interrogated what is actually happening across all of the different key developmental stages. So including neonates, infants, children, adolescents, and young adults, and breaking them down to understand what is the actual difference in cardiac parameters between preterm and term-born individuals. Now, what we've found in this, from this actually, is that many of the changes that are seen into young adulthood actually start to emerge in childhood, in neonates. So things like the smaller right ventricle and left ventricular volumes, but also things like the reduction in right heart pump function, so systolic function, as well as the ability of the left heart to relax and fill with blood, so diastolic function, which actually worsens with age as well. But we also showed that even from childhood into young adulthood, we have this accelerated rate of hypertrophy of the heart.
Is there any protocol that kids can do to help strengthen their heart? What if they're put on like a light exercise program, ongoing early for a long time? Is there anything that can be done? Because perhaps they still have quite a bit of stem cells running around in them, and maybe the heart can remodel if there's an intervention early enough.
Yeah, it's a good point. So you mentioned a little bit earlier about what some of the interventions or that normally happen in clinical practice early in life, so in those kind of first months. But of course, like you said, the heart is continuously developing throughout life as well. So although there may be that really negative period early on, negative in the sense of abnormal development early on with these individuals, there must be a way that we can at least improve cardiovascular function throughout development as well. And I think your mention there of things like exercise has been a primary focus for us, actually. So looking into lifestyle interventions like nutrition and diet and exercise to kind of promote a heart healthy lifestyle and reduce that risk is still under investigation. So we're actually running we just finished our last visit and just performed the data lock for our randomized control trial in young adults of preterm and term-born individuals that went through a 16-week exercise intervention. So these were people that were either born preterm or term, had elevated or stage 1 hypertension, elevated blood pressure or stage 1 hypertension, were relatively sedentary at the beginning, and the intervention actually involved three exercise sessions per week with a personal trainer for that 16-week period, and it was with intensities about 60 to 80% of maximum for the aerobic training for roughly 45 minutes per session. So relatively intense, but very aerobically stable exercise intervention.
I know, that's great. Perhaps other things like low impact things like meditation may work. I don't know. I mean, I guess there's a lot of things that could be tried.
Yeah. One of the good thing with this field is that and to mention, going back to the meta-analysis, we actually identified since 2013, which is when our first big paper came out in circulation describing the left heart, and then a few months later published in circulation again describing right heart changes. Since then, what we found was actually there's 32 unique research studies that had been done, and that's what we've described in the meta-analysis. And I think the good thing about that is that there's more and more people researching this area to be able to understand what's going on and taking different approaches to understand potential mechanisms as well. But what it also means is that there's now wider discussions between different allied health professionals, scientists, and also with patients and participants to understand what are the best ways of actually intervening as well, and what can be done in terms of raising awareness within this space.
What are parents told? I mean, is there enough confidence in what may happen that parents are told, hey, your child will have a harder time with hypertension and may have more heart problems later in life, and if there's clinical trials to be done, is it very difficult to do because there's kids involved, or is it easier to do because the parents will say yes, I want to see if there's anything we can do to help my child. So, what's the situation there?
So I think in general, what we've found is that actually a lot of preterm born people and their parents are very willing to take part in research studies and are very wanting to get more information as well. And I think that's a good thing. I think the other thing to assure people is that just because you were preterm and you have some of these, you may have some of these cardiac changes, it doesn't necessarily mean that you're going to immediately have heart failure or heart attack or any of those things as well. It just may increase your risk, but those things are still fairly rare in the early life period. So if we look at heart failure from non-congenital causes, it's less than 1 in 100,000. So even if you have what we see in the extremely preterms is a 17-fold increased risk, which sounds huge, it's still a fairly rare occurrence within that population. So providing that realistic information and context, I think, is important. But I also think that having that engagement early on, like I said, is an important component in terms of being able to incorporate that healthy lifestyle components and ways of monitoring. So if hypertension is developing, for instance, which is one of the most widely reported cardiovascular changes in preterms, if that is developing, isn't being managed with lifestyle interventions, having that monitoring to be able to then intervene from other angles, such as pharmacological means, is a positive. The fact that you've had that more continuous monitoring and being able to catch those things earlier to prevent long-term, more serious cardiovascular events.
Okay. Very good, Adam. What's the best way for people to find out more? And if, unfortunately they see that they're going to have a child that's going to be preterm, what are some places they can go to for information? You and beyond you, where can they go?
So I think there are some very good websites that talk about what happens, say, or organizations that talk about what happens in terms of the immediate stages of preterm, but also in terms of long-term as well research, especially bigger research studies, which have provided more concrete evidence. So things like March of Dimes always has a lot of good information on that space. In the UK, there's also several charities, so Bliss is one here. But I think those kind of things, so going to to March of Dimes, even the WHO provides quite a bit of information as well. But I think the big thing and the hope is as well, especially talking to a lot of my clinical colleagues, is that GPs and other clinicians become more and more familiar with this as a potential risk factor and start to be a resource for that information as well.
Very good. Adam, thanks for coming on the podcast. I appreciate it. This is an important issue. These poor babies they're born early, at least they're able to survive, but it'd be nice for them to live normal lives as possible. So you're doing a good thing. Thank you for coming.
Great. Thank you for having me.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.